Right. Guys, turn your cameras on. Let's start today's class. See some faces. Right. Okay. So how is everyone? Huh? I actually had a very interesting day today. So I met a patient, very interesting case. So I work at the rheumatology section at the moment. And so this patient comes in complaining of some pain in the hip area and then some knee joint issues, right? So most commonly, guys, out in the rheumatology section, medicine, not pediatrics, medicine rheumatology section, majority of the cases are osteoarthritis, rheumatoid arthritis, things like this, right? SLE and all, not that common in our country at least, right? So initially the mind goes to those, right? Rheumatoid arthritis, osteoarthritis, things like that. But the thing is, she's 27 years of age, right? 27 years of age, relatively short, about 5 feet in height, right? 4'9", 5", right? And she comes in, I take the history and everything, and when I'm going to take her blood pressure, I notice that her eyes appear a little bit blue. Her sclera appear a little bit blue. And she was wearing glasses. So I thought naturally, okay, maybe this is the blue filter. You know, some spectacles, you get the blue filter, right? But then just to be sure, I was like, could you please take your glasses off? And then she took the glasses off and then her eyes look scary blue. It's really blue. The sclera are blue. And then now I have an issue, right? Bluish sclera plus some joint pains. Then I further asked some history. How long has this been there? Since birth. Since birth. Since birth. And the patient came in with her mother, and the mother says to me, she was born in Kuwait, right? And the hospital actually diagnosed some sort of problem with the bones when she was born, and the hospital got an award also for that diagnosis because it was very rare. It's very rare. What do you all think it is? Immediately, some problem with the bones from a very young age plus bluish sclera. A very rare condition, guys. Something called osteogenesis imperfecta. Have you all heard? Osteogenesis imperfecta. So basically, it's a collagen disorder. Collagen mainly involving type 1 collagen, right? You all know bones have type 1 collagen. So sclera also has type 1 collagen. The reason for the bluish discoloration of the sclera is that the collagen is so thin that you can see the underlying vasculature, right? That's why it's bluish in color. Yeah, so I mean, it's off topic, but the first time I met osteogenesis imperfecta patient in the adulthood. It's not a very severe case, obviously. That's why her life has been all right. She actually has a child as well. But now she's having manifested at the age of 27. She's having manifestations of osteoarthritis, right? So my sir, the sir that I'm working under, the consultant, he said we should take some imaging, right? X-rays and some MRIs just to make sure the spine is not, there's no problem with the spine. And then, yeah, to move on to further management, right? So very interesting case today. Right, that was the highlight of my day. So I share it with you. Okay, right. Let's start today's class. Multiple myeloma, right? Multiple myeloma. Now, okay, I'll share the screen. Tell me anything you all know about multiple myeloma. What do those two words mean to you all? Anything at all. Unmute and talk, guys. We'll make it an active class. Sorry?
Type of
cancer of plasma cells.
Cancer of plasma cells. Okay, excellent. Let me adjust this a little bit. Guys, can you all see the screen? All good? Yeah. Okay. So, wait. Yeah, there we go. Right. A cancer of plasma cells. Excellent. Anything else? Anything else? Anything? Have you all met a myeloma patient? Have we talked about myeloma before in Medicine 101 modules?
Backache.
Yep. Good. Excellent. So one student remembers. Backache. One of the main manifestations. We talked about this under rheumatology, right? Right. Multiple myeloma. Look at this, guys. Let's start off today's topic, right? Multiple myeloma, guys, it's a white blood cell disorder, right? A white blood cell, basically a cancer. These are called, guys, lymphoid neoplasms, right? Lymphoid neoplasms. These lymphoid neoplasms, guys, based on the origin, we can divide them into separate types. This is just the introduction. Based on the origin, let's say the neoplasm is originating from mature T or B cells. Then we call it a lymphoma, guys. Now we will talk about all of these in the upcoming chapters. Lymphoma. If it is originating from an immature T or B cell, right? This is when we call them leukemias, guys. Okay, leukemias, right? And specifically, if they are originating from a plasma cell, these kind of neoplasms, we call them myelomas, right? Myelomas. So today we are going to talk about this plasma cell neoplasm, multiple myeloma. Now, here, guys, the basic concept is this. The basic concept is that there is a malignant proliferation, right, of the plasma cell that is leading to an, what do plasma cells normally produce, guys? What do plasma cells normally produce? Antibodies, right? Antibodies, basically immunoglobulins, right? So there is a malignant proliferation of plasma cells that is leading to an overproduction of immunoglobulins. Okay, this is a basic concept, right? Then we will dive deep into this and see what is happening, right? Now, before we talk about multiple myeloma, guys, we need to get some basic physiology out of the way, right, to understand this topic, right? So we'll talk about some concepts. The first thing, I want you all to know this plasma cell. What is it, right? Plasma cell, guys, this is basically an activated B cell, right? An activated B cell. And if you look at the structure, guys, you will see the nucleus of plasma cell is usually towards one corner of the cell. This is what we call an eccentric nucleus, right? And then if you look at the genetic material in the nucleus structure, right, you can see radially arranged chromatins. This is what we call, guys, a cartwheel appearance, right? Something like this, right? Radially arranged chromatin, right? Something like this, cartwheel appearance. Okay. Then, guys, in a normal plasma cell, also just next to the nucleus. Now, a plasma cell, guys, what do you all think? Is it basophilic in nature or eosinophilic? When you stain it, is it more blue or is it more pink? Pink reddish or blue purple? Yes, these plasma cells, these white blood cells, right? They are basophilic. So these are, guys, generally basophilic. Guys, don't color this. I will tell you all when to color. Now, don't just stop drawing for a second. These plasma cells, they are basophilic in nature, right? So they take up a bluish stain. The important thing, guys, in normal plasma cells, just close to the nucleus, there is an area that doesn't take up the stain, something like this, right? So let me draw this structure, something like this. This area doesn't take up the stain. This is what we call a perinuclear Hoff, right? Perinuclear Hoff, guys, this is nothing special. This is just the Golgi body. This is a Golgi body of the cell, right? These Golgi bodies, they do not take up stain. They do not take up the stain, right? So they appear like a colorless region just next to the nucleus, right? Okay. Then what do we know? These guys can, later we'll talk about how they do all of these, produce the synthesize and produce the antigen specific antibodies. This is how they do, right? We'll talk about clonal expansion and all of that, don't worry. Then the next important concept along with this that we need to understand for this chapter is the structure of these antibodies, right? We need to have a basic understanding here as well. If we look at the structure of the antibody, these are all revision for your first year, second year work, right? What is this? We have, guys, an antibody, right? They have what we call a heavy chain and a light chain, right? Yes. Right. So this purple sort of one that I've drawn, this is the light chain, and then the large ones in the center, these are the heavy chains. And how are they joined together? They are joined together by disulfide bonds, guys. Okay, disulfide bonds, right? This is how they are bound together. This is the structure, basic structure, right? Now, what I want you all to know, guys, these heavy chains, light chains, what are these? What are these? What are these? Heavy chains, light chains, what are these? Are they metal? Plastic? Proteins, right? They are proteins. They are proteins. Now, the important thing is if they are proteins, they were coded for by some sort of gene, no, guys? You all understand that, no? Right? Here, for these genes, there are what we call isotypes, guys. Look at this. For the heavy chains, there are 5 different isotypes, right? There can be G, A, M, E, or D, right? This is what forms our IgG, IgA, IgM, like that, right? These are isotypes. For the light chain, guys, we have only two. Right? Either kappa or lambda. Right? Now, let's use our common sense for a bit, right? Common sense question. Tell me this, just based on this information, under normal physiological conditions, right? Should heavy chains be produced in an excess or light chains be produced in an excess? What do you all think?
Light chains.
Light chains. Why?
Because it's only two components.
Only two types. Understandable, no? Only two types. So because they have to join together, right, to form antibodies, the heavy and the light. So because there are only two, light chains need to be produced in excess to join with all the other 5 subtypes, right? Because there are 5 isotypes of heavy chains. Everyone clear with that? Very important concepts, right? Okay. So because of this, guys, usually in our body, right, light chains are produced in excess. Still we are talking normal physiology, light chains in excess, right? To make sure there is enough to bind with all the 5 different isotypes of the heavy chains, right? Usually, guys, they are produced in excess, and anything that is too much, right? Anything you can say anything too much, right? What will happen? That means anything that is produced too much that won't get a chance to bind with the heavy chains. Anything that is too much will be excreted in the urine. Why? These light chains, just as the name suggests, their molecular size is very small, right? They're very light. They can easily exit through the urinary system, right? So this, when they exit through the urinary system, guys, usually in normal individuals, it is less than, we lose light chains in urine about 10 milligrams per day, right? Very small amount. This is normal, right? Okay, now look at this. These light chains, what do you think? Can we detect them on dipstick? In a normal person?
No,
What do you think? Why not?
because it's globule.
Because it's
Globule. Globulin.
right. Excellent. Excellent. So basically, guys, the structure and the amount is very small, right? So these globulins, it's very difficult to detect on dipstick, right? However, one way we can detect them is through electrophoresis, right? Of the urinary sample. That one everyone knows. There is another easier method and a cheaper method to detect them other than electrophoresis. Anyone knows? How can we detect them? Sorry? Okay. Right. Guys, what we can do is there is a method. Now, first thing I want you all to know, when it's less than 10, even this method won't detect it. Right? Later we will see in the pathology, this is going to be above 10. Then only we can detect this. But just for you all to understand, there is an easier method to detect this. We take the urinary sample, we heat it to 50 degrees Celsius. When we heat it to 50 degrees Celsius, guys, we can see at the 50-degree mark, we can see clumping of the proteins. They clump together. And then you keep heating it and you go up to 100 degrees Celsius. And at 100 degrees Celsius mark, this one becomes liquid again, right? Okay. This is what? What proteins are these behaving this way? Huh? What are these proteins behaving like this in urine? These are called, guys, Bence-Jones proteins, right? Proteins, right? Later we will talk about how we will see these in the actual myeloma disease. This is, I'm just telling you all, in a normal person, right? These proteins are less than 10 milligram per day, so not detectable, right? Later we'll talk about. Right. So this is some first few concepts that I want you all to understand, right? The second concept, right? Plasma gel electrophoresis. Plasma gel electrophoresis. What is this? What is this? This one, guys, we know this, right? You all have, I think, studied this. Basically, what we do, we take the sample, right? Okay, put it somewhere there, and we have a negative terminal, and we have a positive end, positive terminal, and we put the sample somewhere here, and then we connect this to a power source, right? This is what we do know. You all know this. What happens? Tell me this, guys. Plasma proteins, are these structures negatively charged or positively charged? Plasma proteins.
Negative.
Negatively charged. Plasma proteins are negatively charged. So when you run them through the electrophoresis, they will move towards the positive charge, right? Something like this, something like this. And the end result, what we get is, you all have maybe drawn this a zillion times, something like this, and then another one, and finally something like this. So let me draw that correctly. This part is a little bit, needs to be a little bit. Yeah, something like that. There you go. Right, this is our, in a normal person. What is this tallest peak, guys? Albumin, right? Albumin, everyone knows this now. Then we have alpha 1 globins, right? Alpha 1, alpha 2, we have beta. In the beta chain, in the beta peak, right? We have a beta 1 and a beta 2 there as well, right? We'll talk about those a little bit later. And finally here is the gamma. Now, our immunoglobulins are what type? Immunoglobulins?
Gamma.
Gamma. Immunoglobulins are gamma, right? Right. So this is another basic concept that we need to be clear about, right? Right. Now, with those out of the way, we'll come to this multiple myeloma. See what is happening here, right? In multiple myeloma, guys, here, there is the plasma cell starts excessively producing one type of immunoglobulin, right? What are we saying here? There, normally, guys, we say there is an antigen coming into the body, right? When an antigen comes, right, it's going to stimulate the immune response, right? We are not going to talk about those mechanisms now, the MHC class 2 mechanisms, right? B cell mechanisms, we are not going to talk about those. Just know we are going to stimulate an immune response, right? Immune response. What is going to happen, guys, right? B cell, we know our B cell. Normally, in the B cell is going to start getting activated and forming a plasma cell with the cartwheel nucleus, right? And this plasma cell, guys, starts undergoing what we call clonal expansion. Now look at this. This is, I'm still drawing a normal person's one. Clonal expansion. What do we mean by this clonal expansion, guys? This plasma cell, right? Draw this. Okay. Draw it first and then I will explain. All of these are plasma cells. Normally, guys, normally, right? When a plasma cell clonally expands as per the requirement that the antigen needs, right? The plasma cell can class switch and produce different types of plasma cells that are capable of producing various types of antibodies. Look at this. This one, let's say this purple, let's say it's the G type, G, right? The yellow one, let's say it's A. This one is, let's say, M. Then green one, let's say D. And brown one, let's say E. So this G1, guys, it will produce this immunoglobulin G type, IgG, right? The A1, IgA, like this, right? All of these, they can produce their specific type. Now, because of this nature of our plasma cell, right, to clonally expand. Now, tell me this thing, all of these antibodies, they can be of different isotypes. But what is the one thing they have in common? What is the one thing they have in common? All of these antibodies that are produced. What is the one thing?
Targeted against a common antigen.
Yes, they are targeted against this single antigen here. All of them are very specific to this fellow. They are of different isotypes, right? IgG, IgM, IgA, whatever. But they are targeted against that specific antigen. That's what they have in common, right? So because of this is the normal physio, right? So because of this, guys, this clonal expansion is what we call polyclonal expansion, right? Polyclonal expansion, because it is producing multiple different isoforms, right? This is polyclonal. This is our normal immune response, guys, right? Normal immune response. Okay. Right. Now look at this. What happens in multiple myeloma, right? In multiple myeloma, guys, okay, what is going to happen? This B cell again is going to mature into a, it's going to get activated rather into the plasma cell. But here is the difference. Here, guys, due to some reason, we'll talk about the reasons later. We'll talk about the causative agents later. Due to some reason, the polyclonal expansion doesn't happen. Instead, it is what we call a monoclonal expansion. Only one type begins overly proliferating, right? Okay, so here I have drawn the same purple type, right? These are all plasma cells, plasma cells, right? Like that. So I have drawn only one color here. So you all also follow the same. And what will they produce? They will produce only that type of immunoglobulin. This is the difference, right? So in multiple myeloma, this is what we call monoclonal, right? Okay, monoclonal. This is in multiple myeloma, right? Now look at this. Now, So let's say this is antigen A, right? Antigen A came in a normal person. Let's say it's stimulated the product. I'm telling these numbers just for your rough idea, guys. Okay. Let's say this antigen A came into the body and it stimulated the plasma cell to produce how much? 1, 2, 3, 4, 5, 6. 6 IgGs. 6 IgGs. Okay. These I'm just giving you all the numbers. Now look at in multiple myeloma what happened, guys? How many IgGs? How many cells in the first place? Right? In the normal situation, one plasma cell produced about 6 IgGs. Okay. Here now we have a monoclonal expansion. So what is happening? Right? Multiple plasma cells capable of producing the IgG, they overproduce. Don't draw a different color. Huh? They overproduce IgGs. When IgGs or when any type of immunoglobulin is being overproduced, guys, we call it a gammopathy. Gammopathy. Pathologically high number of immunoglobulins, right? Gammopathy. Right? Okay. So this is why, guys, multiple myeloma, you put these words together, is called a monoclonal gammopathy, right? Monoclonal gammopathy. Okay. Right. Now, here, guys, later we will talk about what structural changes are going on here. But just tell me this. Now, this monoclonal expansion, it is normal or abnormal? Is it normal or abnormal? Abnormal. If there is abnormally hyperproliferating cells, what do we usually call it? Hyperproliferation of one type of cell somewhere in the body. What is it usually? Uncontrolled division. Yeah, it's usually a cancer. Right? So this is also a cancer. This is a plasma cell neoplasm. Now here's the thing, guys. Due to the malignant nature of this disease, we will talk about the structural changes later. What I want you all to understand, these antibodies that are produced, right? Their functionality is also abnormal. Do you think they will nicely go and attack this fellow now? They don't, right? That's the important next point to understand. These antibodies, guys, these are dysfunctional, right? Why they are dysfunctional, we'll talk about them, right? We're going to talk about the protein folding responses and all of that we'll talk about. For now, just note these antibodies are dysfunctional. Because they are dysfunctional antibodies, right? Someone else came, some scientist came, he said, guys, let's stop these antibodies privilege. Let's stop them from calling themselves antibodies. Let's call them paraproteins, right? Paraproteins. These are dysfunctional. So we are not calling them antibodies anymore. We call them paraproteins, right? So now several things about multiple myeloma you all know. Multiple myeloma is a monoclonal gammopathy, right? And if you look at the blood of a multiple myeloma patient, can you all tell me in some medical terms now what you will see? Just one word. What will you see?
Hyperviscosity.
No, we'll come to those later. Just from the words that we've talked about here. Now, if I'm saying, okay, in my blood, albumin is high, what will you tell that I have in my blood? In a medical way, how will you call it?
Albuminemia.
Albuminemia. Now I'm saying in multiple myeloma, these patients, they are going to produce a lot of paraprotein. What do we see in their blood?
Paraproteinemia.
Paraproteinemia, right? Paraproteinemia. This is what we see in a multiple myeloma person's blood, right? Later we'll talk about, you're correct, the viscosity and everything we'll talk about, right? We'll talk about this, right? Right. Now, so this is what is this, some still we are just going on the surface. We'll dive in deep little by little. Now, guys, here is another thing that I want you all to know. When considering the heavy chains, right? Usually, guys, now what is happening? one specific type will be monoclonally expanded, and that specific type of antibody is the one that is going to be produced in excess, right? So commonly, guys, what do we know now? For an antibody, we have a heavy chain and a light chain, right, which are joined together by disulfide bonds. Here's the important thing. In multiple myeloma, guys, the most common heavy chain involved is the G isotype, and the most common light chain involved is the kappa isotype. So monoclonal gammopathy in multiple myeloma, the most common type of antibody produced is what?
IgG.
IgG, guys. You can say IgG kappa, right? IgG kappa. This is the most common one. Okay, IgG kappa type. Now, why is it mostly the common cause? That's a question we still don't know the answer for, right? Actually, guys, we don't know why, right? But right, not necessary, definitely not necessary for our level to understand. I mean, we don't really understand why it is the most common one, right? After IgG, so basically, guys, if first one most common is IgG, then we have IgA, right? Then M, right? Then D followed by E. This is the usual propensity, right? For us to show. Right. Okay. Now look at this. Fine. So now what do we know? There is a paraproteinemia. The gamma globulin production is going to be very high. How will we see this on electrophoresis, guys? Electrophoresis. What do we see?
M spike.
Excellent. So this is the normal one. Here, guys, in the gamma place, we have a shooting upwards like this, right? This is what we call an M spike. Why M spike? Why M? Monoclonal or multiple myeloma. You can remember it however you want. Monoclonal. M for monoclonal, M for multiple myeloma, right? This is what we call the M spike. Right? Okay. Right. Here, guys, just put a note on the side, because we are not going to discuss this anymore more than this one sentence that we are going to just write down. Put it as note, right? What did we say, guys? The most common one is IgG, right? Then the next most common one is IgA, right? Actually, guys, the third one, right? The third most common one is what we call a pure light chain myeloma. Right? This one we are not going to discuss, right? This is not in our not for MBBS, right? This pure light chain myeloma, just from the name, can you all just come up with what do you all think this means? What do you all think this means?
There is only light chain production, like there's more light chain production than.
Excellent. Due to some cause, we are not going to talk about the causes or anything. Just light chains are very, very high in their blood, right? The others, the G, the A, they are not affected, right? This is what we call a pure light chain myeloma, right? We are not going to discuss this. This is not necessary for us, but just know there is something like that. And when there is a pure light chain myeloma, what is your number one diagnostic there? Number one diagnostic. Huh? We have already talked about at the start. Urine, what will you see? Huh? Sorry?
Going to have clumping at 50 degrees.
Yes, excellent, right? Benz-Jones proteinuria. Jones proteinuria, right? You will see that specifically in pure light chain myeloma. Now we will see in other forms of myeloma also we can see it, Jones proteinuria, but in pure light chain myeloma it is marked and characteristic, right? So that's it. We'll leave that discussion there, right? We are not going to talk about that. Our focus is this IgG kappa type, right? This is what we need to talk about, right? Right. Okay. Look at this, guys. So what do we know up now? Multiple myeloma is a paraproteinemia. Paraproteinemia. Look at this, guys. This brings us to the next point. Paraproteinemias, right? A paraproteinemia, guys, without any clinical manifestations, right? Paraproteinemia, write this down, huh? Without any clinical manifestations, right? For this condition, guys, we give a special name. Write this down, MGUS, right? What is this? Monoclonal gammopathy of unknown significance, right? MGUS, monoclonal gammopathy of unknown significance, right? Okay, this is basically a paraproteinemia without any. So usually it's an accidental finding. You take the patient's blood to look for something else, and then you do some gel electrophoresis and you find out this patient has paraproteins in their blood, right? This is what we call the diagnosis. The diagnosis of that case is MGUS, monoclonal gammopathy of unknown significance, no clinical manifestation. This one, guys, just put a note here. This one is a relatively common finding. It's a relatively common finding. It is associated, right? Associated with aging, right? It is associated with aging. We say, guys, we can see in the population of people who are greater than 50 years of age, right? We can see MGUS in greater than 3% of all people above the age of 50, right? 300 people, right? No manifestations, nothing, no problems, no clinical manifestations, nothing, right? It's just associated with aging. Asymptomatic and benign, you all can write that. Asymptomatic, and it's a benign condition, right? Okay. And in these patients, guys, again, these are an accidental finding. So let's say you do a bone marrow biopsy in them due to some other cause, right? Okay, to look for something else, you not accidentally, you plan and you do a bone marrow biopsy, right? If you do a bone marrow biopsy, what will you see, right? Again, this is a monoclonal gammopathy, right? So you will see plasma cell infiltration at about 5 to 10%. It will never exceed, it will never show that the amount of infiltration is greater than 10%. No, that is in multiple myeloma. We'll talk about that. It is usually 5 to 10%, less than 10. Remember that, less than 10%, right? Right? And the prognosis is good, guys. Prognosis is good, not an issue. Just remember, about 1/5 of, now what did we say? First thing, it's there in about 3 out of 100 people over the age of 50. Out of that 3, right, like that, 1/5 of that amount will progress to multiple myeloma. So this is not a very big number, guys. It's a relatively small number, right? So it's not a very big issue, right? Right. Then when we have a paraproteinemia plus some clinical manifestations, this is, right, when we call it multiple myeloma. Now here there are some diagnostic criteria, guys. We'll talk about those in the diagnostics part, right? There are some criteria that needs to be adhered to in order to diagnose multiple myeloma, but we'll talk about that later, right? Right. Then just a few points about the epidemiology, guys. I think I've put it in your skeletal notes, right? Look at this. 10% of all malignancies, right? All hematologic malignancies. So it's relatively common. And then males greater than females, guys, actually about twice. Finally, a male problem, no? Right? Okay. Males risk is higher, about twice. Median age at diagnosis 60 to 70 years. So if you all, after today's class, if you all think, based on the clinical manifestations I learned today, maybe I am having multiple myeloma. No, right? You all need to go to the psychiatrist if that is the case, right? Something else is wrong. Okay. Very, very unlikely below the age of 40. Below the age of 40, guys, 98, 99% of the cases are at the 60 to 70-year-old age group. Okay, right? Highly unlikely. And relatively, like you get about 4 in 100,000 cases. This is in the Western world, guys. This is from sources like UK and the US, right? In our countries, it's a little bit even more less. Okay, even more less, right? South Asia, right? So these is some epidemiological points, right? Let's get back to the class. Now, after these concepts, everyone clear up to this point, what we have discussed about, we've sort of discussed normal, what we've compared is, guys, a normal person and a myeloma person. This is what we've been doing for the past 40 minutes, right? Now we'll dive into the pathophysiology of this multiple myeloma, right? Pathophysiology, right? Okay. So what is the cause, right, of this cell B plasma cell malignancy? What is the cause? This is the question, right? What is the answer? We don't know for sure, right? But let's see, right? Look at this. Look at this, guys. What we have found out through science, right, and our hypothesis and our testing is that we have a pre-malignant condition, right? And that there are some added effects and there is a genetic component, right? Put the genetic component there in the stars, right? And we have some further added effects. We'll talk about what these are, what these genetic components are. We'll talk about everything. And finally, this results in the malignancy, right? This is the basic hypothesis of what we know. The pre-malignant condition is, guys, MGUS, right? What is this? Monoclonal gammopathy of unknown significance. And the malignancy is multiple myeloma, right? Okay. How it progresses from this pre-malignant condition to the malignancy is the issue, right? Okay, right. So let's see. There are multiple, guys, multiple proposed mechanisms, right? If we look at our textbooks, right, there is only very few that are relatively accepted to date, right? Those also, they are not 100% sure of the mechanisms, right? If you read the textbooks, they will see probably, you will see the word probably used a lot, right? Probably through this mechanism. So we'll talk about those accepted ones, right? The first one, the first proposed mechanism, guys, right? There is something called, right, a chromosomal translocation. Right? This one, guys, in brackets, put it cyclin D translocation. Now I have a question for those students who came for some of the previous modules. Actually, I did it as a free session. If you all remember, I did a session called molecular basis of oncogenesis, right? If you all remember, there we talked about this cyclins, right? How many of you all remember what cyclins do? Cyclins, what do they do? What did they do? On the basis of oncogenesis, not other functions of cyclins. Cyclins have a lot of functions, right? When it comes to tumor genesis or carcinogenesis, oncogenesis, what do cyclins do?
It help in transfer of
Transfer of, right? What do cyclines do in the cell cycle? Does anyone remember? In the cell cycle? No? You all remember the cell cycle, no? G1, S, G2, M, and then it can go to quiescence, or there's a cell cycle like this. Where do cyclines come in this cell cycle? Does anyone remember? No? Right.
Is it between the G1 and the S?
Excellent. Excellent. That is where cyclines work. Cyclines, guys, right? I actually haven't uploaded that video on YouTube. So what I will do is tonight I will upload that video, that lecture, right? If anyone's interested, I will share just drop me a message. I will share the link. You all can watch that in your free time. That's about a 4-hour lecture, I think, on oncogenesis, right? We have talked about all of those mechanisms there. Basically, what cyclin does is, guys, it helps the cell cycle to go from this G1 to S, right? It helps the cell cycle to progress. There is a checkpoint there, right? Cyclin comes, if you all remember, we talked about how it phosphorylates the retinoblastoma protein. A lot of things we talked about, right? Anyway, end of the day, what it does, it helps the cell cycle to progress from G1 to S, right? Now what is happening, guys? There is a chromosomal translocation of this cyclin gene, cyclin D gene, right? Let's take a look at what is happening. Let's draw two. One, I want to show you all is chromosome number 14. Draw this. This is chromosome number 14, right? And then another one, you all can draw it in a little bit of a different color and a little bit larger. Chromosome number 11. Chromosome number 14 and chromosome number 11. The cyclin D1 gene, guys, the CC, we call this so cyclin is the protein, CCND1 is the gene, right? CCND1, cyclin is the protein that this gene produces, right? So this CCND1 or the cyclin gene is present in chromosome number 11, guys. Look at this in the long arm, somewhere here. I will draw it this like this. This is the CCND1 or the cyclin gene, right? Cyclin gene, right? Then the translocation happens with chromosome number 14, guys. Look at this. Chromosome number 14 has another important fellow here. Somewhere here, again in the long arm, chromosome number 14 has the genes that code for immunoglobulin heavy chains, right? Heavy chains, right? They code for the heavy chains. Do you all remember? G, A, M, D, E, right? Whatever isoform. In chromosome number 14, we have that. Now, look at this, guys. The translocation happens like this. You all can take another color, make a small cut there and a cut here, right? This one comes here and this piece goes there. Okay. What is the end result, guys? What is the end result here? The new chromosome number 14 looks something like this. Let me draw this. Maybe this one. Take this one. Put it here. There we go. That's the new chromosome number 14 and the new chromosome number 11, right? Looks something like this. Looks something like this. Okay, this is after the translocation, right? This is the new chromosome number 14 and this is the 11. Okay. Right. Now, what happened here? the cyclin gene was translocated and it came just adjacent to where this immunoglobulin H chains are being produced. The gene, the IgH gene, right? The heavy chains, right? Right. Now look at this, guys. Here's what I want you all to know. Guys, turn your cameras on. Only 2 students have turned their cameras on. I can't see your faces. I don't know what is going on. Turn them on, turn them on. Otherwise, I'm not getting a feedback from you all also. Right. Right. Look at this. What is happening here? What do you all see here, guys? The CCND1 or the cyclin gene has come now just adjacent to the IgH chain genes, right? The heavy chain genes, right? The important thing I want you all to know, guys, cyclin, if you all remember when we discussed in the molecular basis of oncogenesis, this cyclin gene is very carefully controlled, guys, right? It is activated only when the cell needs to go from the G1 to the S, right? And as soon as the cell goes there, it is inactivated, right? Like it is activated and in a very controlled manner, highly controlled manner, right? So what is happening here? How is this controlled, guys? In the normal chromosome number 11, there are surrounding genes that help to activate or inhibit the CCND1 gene, right? The cyclin gene. Now what is happening when the cyclin is translocated to 14? Does chromosome number 14 have these inactivators or inhibitors or activators of the cyclin D1? No. So here, once the cyclin D1 gene gets activated, it will not stop. It will keep on progressing the cell cycle, G1S. It will keep on going. And this is what causes, guys, this is the cyclin D1, right? We have cyclin D1 overexpression or uncontrolled expression, right? After the translocation, right? Why? Because the chromosome 14 does not have, right, any other inhibiting genes, right, or controllers for the cyclin D1. And therefore, what happened, guys? There is going to be uncontrolled proliferation, uncontrolled cell proliferation. So this happens in what cell? The plasma cell. So this is why we get a clonal expansion of one specific type of cell, right? This is one of the proposed mechanisms, right? Did everyone understand this chromosomal translocation? 1114, 1114, all good, right? Right. Then the next one, the second proposed mechanism. These are all, guys, proposed mechanisms. Here's what I want you all to know. These proposed mechanisms, we cannot say one is the best one, right? Okay, there is a lot of evidence supporting each one, right? Sometimes all of them might be happening together. We don't know, right? Sometimes none of them might be happening, but these are what we know up to now. The second proposed mechanism is what we call hyperdiploidy, guys. Hyperdiploidy. This is for obvious reasons, right? Just from the word, right? What do I mean by hyperdiploidy case? Now, what is our normal chromosomal number? How many chromosomes do humans have? How many? No? How many chromosomes do humans have, guys? Tell, unmute.
46.
46. Excellent. 46. We have 46 or 23 pairs. 23 pairs. In hyperdiploidy, what is happening, guys? We have more copies of chromosomes, right? So it might be 48, 49, 50. We don't know, right? So for obvious reasons, let's say we have hyperdiploidy involving chromosome 14. That means we have more copies of chromosome 14. If we have more copies of chromosome 14, what is the most important fellow in chromosome 14? Immunoglobulin heavy chain genes. So if we have more heavy chain genes that are able to be activated, what will happen? The gammopathy. This is where we can get monoclonal gammopathy, right? Gamma globulin production will be high. Then same, Another one, let's say chromosome number 22. This chromosome number 22, I didn't tell you all yet, guys. Chromosome number 22 holds the genes for the lambda chains. Lambda chains. The light chains, remember light chains? Lambda, right? So if we have a hyperdiploid state involving chromosome number 22, what will happen, right? Immunoglobulin, light chains, or in other words, lambda will be very high, right? Same chromosome number 2. Chromosome number 2, guys, it holds the genes for kappa, right? So immunoglobulin, again, light chains, in this case, kappa will be very high, right? So this is hyperdiploidy, right? Hyperdiploidy. Then apart from these guys, we have a lot of other causes, right? Proposed mechanisms, which we are not going to discuss. There is something called monosomy 13. There is 13-8 translocation, right? Not necessary. These two are the ones I want you all to know, right? Hyperdiploidy, translocation 11-14. Translocation 11-14, basically translocation of cyclin D1, right? Is everyone clear about these two mechanisms? Give me a thumbs up. Let me see some faces. Can't see faces also today. Okay, one thumb is going up. Dilshani, understood? No thumbs? No? Okay, good. Thumb is going up. Right, good. Right. So I hope you all understood. These are the proposed mechanisms and the most accepted ones. Right. So based on these guys, why IgG class is the most common, we don't know. We cannot understand based on these mechanisms. Why G is the most common one, we don't know. Why kappa, why IgG kappa subtype is the most common, again we don't know. Right? So what did we say? There is MGUS that is going to progress to multiple myeloma, and the genetic component is what we have discussed up to now. We have talked about the translocation, translocation 11-14, and the hyperdiploidy. That is the genetic component. Then what else can amplify the effects or the progression into these genetic problems, right? There are some things that they have noticed, guys, some associations rather with this disease. For example, they have noticed pesticides, some pesticides, guys, right? When humans come into contact with some pesticides, right? These can help. Exact etiologies, we don't know. Exact mechanisms, we don't know. But these are associations. Benzene, right? Benzene compounds, right? Okay. Various petroleum, cracked oil, crude oils, cracked oils, petroleums, right? Apart from this, dysregulated apoptotic mechanisms. You all know there is something called apoptosis in our body, guys, something called programmed cell death. If that doesn't happen also, what can happen? Cells can hyperproliferate, right? So we don't know why exactly, but these things they have found to be associated, right? Another one, you all can write this down. These are just words. Altered tumor microenvironment, right? It's just I'm telling these words for you all for the completion of the class, but we don't really know what is going on in these areas, right? Okay, so this is the basic pathogenesis of multiple myeloma. Now, right? So this one, guys, up to now what we discussed, we can sort of name this as the phase 1. Why I'm saying that, now we will see after this genetic effects come into play, there is another mechanism that is going to come into the whole pathophysiology, right? So that is what we will be discussing now, right? The phase 2. Before we go to the phase 2, guys, we'll talk a little bit again about some normal physiology here, right? Plasma cell. Plasma cell, what do we know up to now? Cartwheel nucleus and the Golgi body, which doesn't take up the stain, right? Another important concept for you all to add to your plasma cell physio, right? Plasma cell, if you look through the microscope, guys, you will see it is full of endoplasmic reticulum, ER. It is full of ER, right? It is full of ER, right? Why? For the protein synthesis. Protein synthesis, because the only function of plasma cell is to produce the proteins, the antibodies, right? So it is full of ER. It is full of ER. If we zoom into one of these guys, if we zoom into one of these, what do we usually see? Something like this, no? Right? And we have the ribosomes, right? The endoplasmic reticulum, right? Basically rough endoplasmic RER with the ribosomes, right? Look at this, guys. Here, the ER ribosomes, they synthesize the immunoglobulins. So they will start producing these chains. These are the immunoglobulin chains, right? Being synthesized by these ribosomes, right? These immunoglobulin chains, guys, they have to undergo proper folding and maturation before they are released into the blood. Just after producing the immunoglobulin chains from the ribosomes, you can't just release them into blood, right? They are nicely folded, right, to get their immunoglobulin, the globulin structure, right? And this folding is done by someone. Look at this, guys. You can draw him like this, right? Who is this? This is what we call molecular chaperones, right? Molecular chaperones, right? Molecular chaperones. These molecular chaperones, guys, they nicely, they bite these, okay, they bite these structures a little bit, right? Let me draw that better, right? Okay. And what they do, they nicely fold them, allow them for maturation, and they will nicely pack them. They will pack them up, right, for transport to the outer cell surface membrane, right? This is what these molecular chaperones do. Guys, just remember the important words here, right? Proper folding, folding of the proteins, proper folding of the proteins plus maturation. Folding and maturation. Okay, very important words. And then eventually this one, right, will be transported, right, like that, out of the ER. It will come out of the ER, and eventually, right, out of the it will come out of the plasma cell as well, right, and be released outside, right? So this is how the antibodies are being released. This is how the antibodies are being released under normal condition. With this knowledge, now we can come into the phase 2, of what is going on in multiple myeloma. So in multiple myeloma, initially we had a genetic plus some environmental effects, right, that helped the MGUS or monoclonal gammopathy of unknown significance to transform into the multiple myeloma. Then we had some additional things going on. This is our phase 2. In our phase 2, guys, you all can put the topic. Phase 2, what is happening here? Right? Look at this, guys. What did we say? In multiple myeloma, we had the monoclonal expansion. Monoclonal expansion. When monoclonal expansion is there, right, the volume of immunoglobulin synthesis will be what? High or low? High. This is what we call a paraproteinemia. A lot of immunoglobulins in the blood, right? So volume of immunoglobulin synthesis is very high. It increases so much, guys. It increases so much to the extent, right, where the capacity, write this down, it is higher than the capacity of endoplasmic reticular molecular chaperones to properly fold them. So what is happening? right? The protein synthesis or the immunoglobulin synthesis is now so much, right, that the molecular chaperones are not sufficient to fold all of these and nicely let them mature before they are being released, right? Okay, this is what this gives rise to something we call, guys, the unfolded protein response. Why is this happening? Because now the molecular chaperones don't have enough time to properly fold them, let them mature. So all of these unfolded proteins are going to start accumulating in the endoplasmic reticulum, giving rise to what we call the unfolded protein response, right? Unfolded protein response. How is this unfolded protein response activated, guys? The mechanisms we don't need to know, but basically, if we look at the endoplasmic reticulum, now what is happening? There are a lot of immunoglobulins, right, that are not properly folded, right, that are filling up the endoplasmic reticulum, right? This abnormal congestion within the endoplasmic reticulum is detected by some receptors, right? We don't need to know the names of these receptors, right? They are just a bunch of letters, guys. Okay, these names of these receptors are just a bunch of letters and some numbers. So no need to confuse ourselves. Just know there are some receptors. When the endoplasmic reticulum becomes overcrowded, they get stimulated and they start the unfolded protein response, right? Unfolded protein response. Everyone clear up to this point? If any question up to this point, let me know. Right, all good? Right. Now, what is this unfolded protein response, guys? It is basically an attempt by the plasma cell, to recover back to its normal function, right? An attempt by the plasma cell endoplasmic reticulum to return back to its normal function. So what happens here? The unfolded protein response, once it is activated, immediately the rate of gene translations will be reduced. Translation will be reduced, right? Cell proliferation will be reduced. Protein synthesis will be reduced, right? Endoplasmic reticulum molecular chaperone production will be high or low? Tell me, molecular chaperones should be produced more or less now?
More.
More. Why? We have a lot of unfolded proteins. We need a lot of molecular chaperones to come and fold them properly, right? And let them mature. So the endoplasmic reticulum will start producing a lot of molecular chaperones, right? Overall, guys, there will be an increase in what we call quality control. This is basically like a factory, no? This is like a factory producing antibodies, producing the protein, right? So quality control, guys, what is basically happening? There will be degrading using lysozymes and all of these enzymes, lytic enzymes. There will be degradation of unfolded proteins, or misfolded proteins also are there. Unfolded, misfolded, both are there. Huh? And then their lysosomes can come to this area, right? Lysosomes, they will, right, cause autophagy, what we call autophagy of cellular debris. This is all an attempt, right, to relieve this congestion, guys, to remove all of these unfolded proteins, right? If all of these fail, write this down in red. If the unfolded protein response is not working after all of this step, the unfolded protein response has one more gun under its sleeve. What is that? What do you all think?
Apoptosis.
Excellent. It can induce apoptosis. This is the last step. If everything fails, the unfolded protein response will induce apoptosis of that plasma cell, right? Okay, right? Now tell me this, guys. The plasma cell, right? if this endoplasmic reticulum is going into stress, right? Here, when this endoplasmic reticulum is full of all these congested proteins, we call it ER stress, guys. ER stress, endoplasmic reticulum stress, right? Endoplasmic reticulum stress. What do you all think? Now, let's say I'm a malignant cell. I'm a malignant plasma cell, right? Now, what do I want to do? I have the tendency to produce a lot of antibodies, right? A lot of monoclonal antibodies. But in that process, my endoplasmic reticulums, which are within me, are undergoing a lot of stress, right? So, me as the malignant plasma cell, would I want my endoplasmic reticulums in such a stressful state? What do you all think? Would I want it like that? No, not really, right? I do want to produce a lot of antibodies, but I don't want my body to go into stress. I don't want my endoplasmic reticulums to go into stress. As the plasma cell, this is my thought process, right? Because of this, guys, right? Look at this, right? Write this down. For the neoplastic plasma cell, right? For the neoplastic plasma cell, the unfolded protein response, right, is walking a very fine line. It's walking a very fine line between what? Look at this. Unfolded protein response. One thing it can do, it can reduce the endoplasm. It can attempt to reduce the endoplasmic reticulum stress, right? By doing all of those first four things that we talked about: reduce translocation, reduce cell proliferation, all of that. It can reduce the stress. So this is a good thing. The endoplasm, the neoplastic cell, the neoplastic plasma cell likes this, right? If someone is coming and reducing your stress, wouldn't you like it? Huh? I know that sounds wrong, but I mean, if you're going to a psychotherapist or something, you would feel better. Same thing here, right? Someone is coming to reduce the stress, so it feels it's good, right? At the same time, what is another thing that the unfolded protein response can do? It can induce apoptosis. Induce apoptosis if nothing works. So this is what, as the plasma cell, right? What is this? Basically, this is suicide, right? This is basically suicide, right? So this is bad for the plasma cell. Bad for the plasma cell, for the neoplastic plasma cell, right? So can you all see the myeloma cells or these neoplastic plasma cells? They are walking a fine line, right, between doing what they want to do, right, which is produce a lot of antibodies, and die, right? They're walking a very fine line between these two. Because of this particular reason, right? This brings us to the last point of our phase 2. Myeloma cells, guys, or the neoplastic plasma cells, they cause mutations. They mutate by themselves. They mutate a number of genes responsible for the unfolded protein response. Why are they mutating these genes that are responsible for the unfolded protein response? Why are they mutating it? Can you all tell me now, based on what we learned? Huh? What do you all think? No idea?
To increase the number of cells, because there are those which undergo apoptosis.
Yes, basically, guys, yes. Basically, what they want to do is keep the good things and stop the bad thing, right? Correct? Agreed? So, what they do, what myeloma cells are capable of doing, right, is they are able to stop the apoptotic effects while keeping the good things going, right? The most important one, there are multiple mechanisms, guys, right? Multiple genetic molecular level mechanisms we do not need as medical practitioners, as doctors, but one important mechanism is that they mutate, right? They mutate interleukin 6 genes, right? Okay, you all know, guys, this interleukin 6, This interleukin 6 under normal conditions, right? It helps to cause apoptosis. Interleukin 6 helps in causing apoptosis. Therefore, when they are mutated, what happens? This prevents apoptosis. Now, due to this cause, guys, now as medical practitioners, now think, as a doctor, how does this knowledge come in handy to you? Huh? Or as a pharmacist, maybe. What do you all think? Huh? Huh? Maybe, right? If we can make a drug to promote the interleukin 6 function, what will happen? See, this is how you have to think. So based on the physiology, right? So this interleukin 6 has been one of the hot topics in the treatment of multiple myeloma, guys. Okay, right? There is still a lot of research going, but this is one of the main reasons, right? One of the main reasons. Okay, did everyone understand up to here? Right? All good? Right. Excellent. Right? Just put a summary here, guys, because I know we discussed a lot of information here. Just put it as summary. This is all I want you to remember from here. There is something called MGUS. I want you all to know what this MGUS is. We've already talked about, right? And MGUS, we know, gives rise to multiple myeloma, right? This is the disease. Right? Then we said there are some genetic factors, for example, the translocation or the hyperdiploidy, right? And then what did we say? There are some external factors that can, by some mechanisms, some associations, we don't know how, but these associations are noted in these patients. For example, pesticides, benzene molecules, right? Altered tumor microenvironment, altered apoptosis, all of these. Then, apart from this, guys, just remember, multiple myeloma, we have the unfolded protein response going on, right? Okay, and what will happen, guys, with the help of interleukin 6 mutations, right? This is able to stop the bad effects of apoptosis and keep the good effects to reduce the stress on the neoplastic plasma cell, and therefore keep on going. This is like sort of like a positive cycle, guys, like a vicious cycle, right? Multiple myeloma, once it develops further mechanisms to keep that neoplasm going and working and prevent its death, right? That's the issue. Okay, so this is the basic thing I want you all to understand here, right? Okay, everyone clear up to this point? All good, right? Then now we'll come to the pathology and the clinical correlate, guys, clinical manifestations, right? You all can put the topic pathology plus clinical correlate. Right? Okay, look at this. Now it's becoming obvious. Now things are becoming little by little obvious. Now you all have to answer, right? Look at this. I'm going to tell you all the first one. First thing, bone marrow plasma cell, they start hyperplasia, right? We are going to see an increase in the plasma cell number in the bone marrow. This is obvious, no? Right? This is monoclonal proliferation, right? This is also what we call, guys, infiltration. When a cell type is very high in a particular tissue, we say this is an infiltration. So bone marrow plasma cell infiltration, right? When this plasma cell infiltration is very high, what do you think happens to the generalized function of the bone marrow? What should happen? Is it disturbed? Anything happening? What do you all think?
This is disturbed.
Yeah, the bone marrow function is going to be disturbed, right? Function is going to be disturbed, right? So what is one of the main functions of the bone marrow? Just from the past few chapters that we've discussed in this module, what is the bone marrow? Hematopoiesis, right? Erythropoiesis, thrombopoiesis, all of these things. So, for example, if the RBC production is going to be affected, right, and it's not properly functioning, what will happen? The patient will develop anemia, right? Now, this anemia, guys, this anemia, what do you think? What type of anemia do you think this is? Is there a problem with load in the hemoglobin there? Not necessarily, right? Not necessarily, no problem there, right? This is usually, guys, you all can write down. This is a normocytic, normochromic anemia, right? It's a normocytic, normochromic anemia most of the time. Sometimes, rarely, right? It can be a macrocytic, guys. This is not very common, right? We'll not talk about that, right? So if the patient is manifesting anemia, what can you see clinically? Now, we doctors, tell me clinically, what are you expecting?
Pallor.
Pallor. How will they come to you? What will they complain of?
Fatigue, weakness.
Fatigue, excellent. That's what they will say. Shortness of breath, fatigue, one of the most common presenting complaints. No one will, guys, actually in the clinic, you will very rarely come and meet a patient who says, doctor, I feel like I'm pale. No, never, right? You're the one who will see that. You're the one who will say that. What they will complain is, doctor, I feel tired, right? I have shortness of breath. I can't do a lot of work, right? I run out of breath. That's what they will complain. Okay. So lethargy, pallor, yes, dyspnea, shortness of breath, all of that. And tachycardia sometimes, right? If there is compensation, right? All of that. Then, guys, just note, anemia is quite common. Anemia is quite common in multiple myeloma. But at the same time, what are the other bone marrow problems? Thrombocytopenia, neutropenia, right? Thrombocytopenia, neutropenia. These ones, guys, for some reason, these ones are rare and are seen only in highly advanced disease. Thrombocytopenia, neutropenia. Right? Now, if there are thrombocytopenia, what are the manifestations? What are some manifestations? Excellent. Abnormal bleeding, gums, epistaxis, right? We've talked about all of these, right? Petechiae, chymosis, anything can be there. These are just note, guys. These are not common, right? Presentation only if the disease is severe. Anemia, yes, anemia, common complaint, right? Right. So that is the first one. Second one, right? What did we say? There is a paraproteinemia. So basically, in the blood, there is a lot of these dysfunctional immunoglobulins or paraproteins, what we call. So in the blood, what is going to happen due to this paraproteinemia, guys? Several things. First thing, can you all just, okay, I'm not going to tell you. Tell me. When there is an abnormal accumulation of proteins in the blood, what do you all think? Anything? Excellent. One thing is hyperviscosity of the blood. The blood becomes a little bit thicker, right? Hyperviscosity of the blood. When the blood is thicker, guys, right? What is one lab test that we can do that will show?
ESR.
ESR, erythrocyte sedimentation rate will be higher. ESR will be higher. And if you look at the blood film, guys, you can see what we call, I don't know how to pronounce this, Rouleau formation, EUX, no? Or Rulex or Rolex, or call it whatever you want. Okay, Rouleau formation. Rouleau formations are going to be high, right? This is in the blood film. These are not clinical manifestations, but I'm just putting all of these here because it's easier, right? Then apart from this, guys, when the viscosity is too high, another thing that can happen, especially with regards to elderly individuals, right? In their veins, what can happen? Deep vein thrombosis, especially if they are not moving, especially bed-bound patients, right? Deep vein thrombosis, possible, right? Another thing, guys, right? Heart failure, this is in very severe cases, not common, guys, this is rare. Heart failure and CNS manifestations. Why are all of these two are rare? Put it as rare. Why are all of these happening, guys? Basically because the blood is viscous, the blood flow rates become very low, right? So gas exchange and everything in peripheral tissues reduces, right? So these things can happen, right? Very rare, obviously, for heart failure and CNS manifestations, guys. They usually need to have other comorbidities, right? Otherwise, they don't usually come about in multiple myeloma, but possible, right? Then the next thing, guys, look at this. Paraproteinemia. Now, the second one I want you all to know. What do we say? Paraproteins, are they functional? Are they functional? No. They are dysfunctional antibodies. Now the issue, guys, when there is malignant monoclonal proliferation of these dysfunctional ones, actually the functional antibodies, functional immunoglobulins start reducing in your blood, right? Okay, because all of these dysfunctional ones are going to start filling up the spaces, right? So the normal immunoglobulins or the functional immunoglobulins start reducing, because one thing, they are going to overcrowd, and the machinery is, all the ribosomes are being utilized for the production of this dysfunctional one. There is monoclonal gammopathy, all of these, right? So the functional ones are going to reduce. What does this result in? When your immunoglobulins start dropping, your functional ones start dropping.
Infections.
Recurrent infections, guys. Recurrent infections. They are more prone, right? Because their immunity is now reducing little by little. Although this is a gammopathy where gamma globulins are high, they're dysfunctional, right? So the immunity drops, right? Then another thing, again with paraproteins, guys. Another thing, right? They are light chain subtype, whichever one is produced, right? Now, what is the most common one? IgG kappa. So kappa will be also very high, right? Whichever one is produced. IgG lambda also can be there. IgA kappa, IgA lambda, all can be there. IgG kappa is the most common one. So light chains are going to be very high. What is the manifestation here, guys? Benz-Jones proteinuria. Okay, Benz-Jones proteinuria, right? So when there is such a lot of light chains, guys, going through our thin nephrons, very tiny nephron structures, what is another thing you can see if you take the urine sample and look under the microscope? Huh? No idea? Those who came for my chapters like nephrotic syndrome and things like that. When you have a lot of protein that is traveling along,
cast.
excellent, proteinaceous casts, right? Protein casts. Under the microscope, you can see this. This is what we call cast nephropathy of multiple myeloma. Okay, right? Okay. Then, guys, the next one, I want you to put it in red under these light chains. Very, very important one. Very important. The light chains that are there, guys, the light chains that are now excessively produced. Are these nicely folded? Are these nicely matured? No. Now, what do we know about immuno? They are immunoglobulins, right? Immunoglobulins. But now, are they having the nice globulin structures? No, because they are misfolded, they are unfolded. Here, guys, because of this, some of these structures that are meant to be globulins, now, because of the unfolding, they form what we call beta sheets. Some light chains are released into the blood in the form of beta pleated sheets, right? They are no longer globulins, they are beta sheets. Now, what are these light chain molecules? Immunoglobulin light chains that are in the form of beta sheets. What are these? What are these?
Amyloids.
Excellent. These are what we call amyloid proteins. Amyloid proteins. Amyloids. We call them amyloids. Amyloids. Correct. Right? Now what's happened? When there is a lot of light chains going into this beta sheet form, and that means what? A lot of amyloids, they start depositing everywhere in the body. This is what we call amyloidosis. Amyloidosis. Now tell me this, guys. What do you all think? Is this a primary amyloidosis or a secondary amyloidosis?
Second.
How many are saying secondary? Huh? Don't worry. Even when I was in medical school, I had a hard time with this. Right. Look at this, guys. This is a primary amyloidosis. Why are we saying that? Look at this. Normally, guys, when we take a disease, right, and some other disease is causing one disease, we call it a secondary, right? So this appears to be something like that, right? But if you look a little deeper, look at this. Here, the beta sheets themselves are coming from what? From the light chain, from the light chain, right? And the light chains are coming because of what? The multiple myeloma, right? If there was some other disease that is causing the already existing beta sheets to start depositing, then that is a secondary amyloidosis. Do you all understand? So we have beta sheets in our body, right? We have proteins in the form of beta sheets in our body, right? If these beta sheets start depositing due to another disease, that is what we call a secondary amyloidosis. Here, in the case of multiple myeloma, the multiple myeloma itself is producing the beta sheets. The light chains are itself the beta sheets, right? So this is, guys, a primary amyloidosis. Don't make this mistake. It's the popular MCQ, right? Multiple myeloma results in primary amyloidosis. True, true, okay? Not secondary amyloidosis, right? Very popular question, okay? Right? Because the beta sheets itself are coming from the light chains itself of multiple myeloma, okay? Right. So we'll talk about amyloidosis a little. Amyloidosis. What do we see? We've talked about these many times. What are some manifestations of amyloidosis? Tell me, guys.
Bilateral carpal tunnel.
Excellent. Bilateral carpal tunnel syndrome. Excellent. Excellent. Anything else? Anything else? No?
Nephritis.
Sorry?
Glomerulonephritis.
Yes. Basically, yes, glomerulonephritis, correct. They can go into renal failure, guys. They can cause renal failure, right? Same way, if they go and deposit, wherever they go and deposit, they can cause problems, guys. If they go and deposit in the kidneys, yes, renal failure. If they go to the liver, hepatic dysfunction, right? You all can write these down, huh? Hepatic dysfunction, right? Amyloid proteins. Sometimes, guys, they can go to the tongue, right? Our tongue and cause macroglossia, right? Large tongue, right? Macroglossia, right? And they can go to our digestive system, right? And this render the gastrointestinal epithelial cells dysfunctional. That will cause diarrhea, right? Diarrhea, all these kinds of things can be there, right? So these are some amyloidosis due to amyloidosis, right? Then, guys, the fourth one under this same point, the paraproteinemia. Here, guys, we have something called a reversed albumin to globulin ratio. Now, in our normal serum, right? How is the albumin to globulin ratio? Who is higher? Who is higher?
Albumin.
Albumin is higher. Albumin is higher. Globulin is a little bit lower. Now what is happening, guys? It's going to be the opposite. Globulins, right, are going to be much higher than albumin. This is, you can see in the you just through the blood test, huh? The protein panel, you can do the protein panel, right? Clear about the paraproteinemia, right? Paraproteinemia, all good, right? Then point number 3. Let's come to point number 3, right? Here, guys, we are going to talk a little bit about this malignant plasma cell. Malignant plasma cell and the related clinicals. The malignant plasma cell, guys, can cause various things. Look at this. One thing it does, right? Now, these are very, write this down, guys. There is something called MTP1 alpha, right? Absolutely unnecessary for your MBBS, right? Okay. This MTP1 alpha, guys, what it stands for is macrophage, sorry, MIP, MIP1 alpha. What it stands for is macrophage inflammatory protein 1 alpha. Macrophage inflammatory protein 1 alpha. This is nothing special. This is just a chemokine. This is a chemokine, right? It's a cytokine, right? Chemotactic in nature, right? Just a fancy name. What it does, right? It goes to the bones, guys, especially our hematopoietic involved bone cells, right? Especially in these bones, especially our flat bones as we age, bones with red bone marrow, right? Here, it goes and does something of what we call rank ligand expression. Don't worry, I will teach you all. These are just big words. Rank ligand expression. Write it down. Right? It's going to increase rank ligand expression. Right? And when rank ligands are high, that is going to stimulate osteoclasts. Osteoclasts. Okay. Before we go any further, you all know this. What does an osteoclast do? What does an osteoclast
Break
do?
down bones.
Break down bones, right? If you all know that much, more than enough, but we'll look a little bit. Medicine 101, we'll learn something extra, right? Look at this. This MIP1 alpha, macrophage inflammatory protein, is produced by the malignant plasma cell. Here, guys, this rank ligand, it looks something like this. It's basically rank ligands, guys. These are a cytokine in the TNF family, right? Rank ligands, right? They're a cytokine of the tumor necrotic factor family, right? So this rank ligand expression is increased where in bone marrow stromal cells, bone marrow stromal cells. What is the feature of this rank ligand, guys? Our osteoclasts are nicely asleep, but they have receptors for this rank ligand. They have the rank receptors. So what happens? These fellows come, bind to these, the ligands bind to their receptors, and thereby what happens? Osteoclast, right, starts getting activated. Osteoclast gets activated, right? Right. Now, this is one thing, right? Another thing, guys, another thing, look at this. Malignant plasma cells, number 2, right? It can secrete another substance, WNT antagonists. I know these are new words, right? Just don't, I don't want you all to memorize these words at all. The first thing I want you all to, from the first point, all I need you all to know is that osteoclasts are activated. But how it is happening, right? We'll have just a basic picture. The second one is this WNT antagonist. What is this WNT, guys? This WNT right? This is a primitive pathway, guys. We have developed this throughout evolution. Evolution or creation, anything you all want to believe, right? Throughout this pathway has been developed, and it has been improving little by little. What is this, guys? This is called wingless related integration, right? Not important. What is happening? WNT antagonist will go and inhibit what we call the WNT pathway. WNT pathway inhibitor, right? Inhibited the WNT pathway. And when the WNT pathway is inhibited, guys, WNT is absolutely essential for osteoblast function. So here, this is going to inhibit osteoblast activity. Now look at this. What did we have first? Osteoclast stimulator, right? Osteoblast inhibitor. Tell me, what is going to happen? What is going to happen? What is going to happen? No idea?
Bone breaks down.
Yeah, bone breaks down. What is the fancy medical term to explain that? Bone resorption. Bone resorption increases, right? What happens when basically what is happening? Bone is being broken down. When the bone is being broken down, what is released from the bone to the blood?
Calcium.
Calcium. Ca2 plus being released into the blood results in what? Serum calcium being high. Hypercalcemia. Hypercalcemia, right? Hypercalcemia, right? Okay. When there is bone, so that is one thing with bone resorption. Another thing, when the bone is being broken down, what happens to the mineral density? What happens to the mineral density? Reduces. We say bone mineral density starts reducing. Bone mineral density starts reducing, right? This I will tell you all later. And then what happens because of this? Initially, guys, they can have what we call lytic lesions or lytic lesions, right? We will see these in the x-rays in a little bit. We'll look at the x-rays. They are basically like someone has punched holes in the bones, right? Lytic lesions, right? Okay, and when this is serious, guys, when the lytic lesion starts spreading, weakening the bone so much, eventually it can lead to fractures. These fractures are called what?
Pathological.
Excellent. These are called pathologic fractures. Pathologic fractures, very important to understand, right? Pathologic fractures, right? Look at this, guys. Just put it as a side note. This bone mineral density reduction, how do we usually identify it? What's the lab test? What's the lab test? There is something, have you all heard, guys, called a DEXA scan? DEXA scan, have you all heard? Right? Right? Dual energy, right? This DEXA scan, this is an X-ray scan, right? A special one. This is the one that we use to identify bone mineral density, right? Okay. Right. Now, look at this, guys. Specifically with this lytic lesion, as the bone is undergoing destruction and getting weaker, what happens? The surrounding nerve fibers of the bones can be stimulated, giving rise to bone pain, right? The patient will specifically say, guys, I feel like my bones are hurting, right? They don't say like a muscle pain, like here is hurting. No, they will say inside, deep inside it hurts, right? Okay, this is what we call bone pain, right? More of a dull kind of pain, aching kind of pain, right? In the inside, and specifically most commonly, guys, affects the vertebral column. Therefore, lower back pain is a prominent manifestation of multiple myeloma, right? Lower back pain. Apart from this, we can have hips and other long bones affected as well, right? Lower back pain, right? Most common one, right? Now look at this, guys. Here's another important thing I want you all to know here. If we have a normal fracture, right? This is surgery, this is surgery knowledge, but we'll just talk about a little. If you fall down, right? If you fall down and you broke a bone, right? In your serum, basically from your blood tests, in your serum, what is one indicator that you have a fracture in your blood? Huh? You all know? Anyone? Guys, turn your cameras on. What do you all think? When there is a fracture, any indicator, is an X-ray the only indicator of a fracture? Huh? Can't be, no? Can't be. We definitely should have another way, right? One other way is, guys, don't draw the arrow here. Huh? Just write it as a side note. Normal fracture, a normal fracture due to any other cause, right? Fractures normally, when there is a break in the bone, they release alkaline phosphatase, right? What we call alkaline phosphatase into the blood. So sometimes, guys, let's say a patient fell, right? A patient fell or had a road traffic accident or something, but on an X-ray there doesn't seem to be a fracture. But you do the serum, you take the blood and you look at the serum, you find the alkaline phosphatase is very high. So there is a possibility there might be a hairline fracture or something very small somewhere that you have missed, right? So this is what happens in normal fractures, right? Why does this happen, guys? Why does this happen? Why is alkaline phosphatase usually released in a normal fracture? When we have a normal fracture, guys, we know, right? Our osteoblasts are going to get stimulated. Why? To heal that fracture. Correct? Osteoblasts, because they are in charge of forming bone. So in a normal fracture, osteoblasts are stimulated, and osteoblasts release this alkaline phosphatase, and that is why in the serum alkaline phosphatase will be high in the serum. Now can you all tell me why in multiple myeloma pathologic fractures, what will happen? Will you see alkaline phosphatase high or alkaline phosphate low? Or normal, not low, huh? High or normal? What do you all? Normal. Here, guys, pathologic fracture of multiple myeloma, alkaline phosphatase is normal. Now there can be pathologic fractures in other diseases, guys. Paget's disease, Brown's tumor, these types of disease, alkaline phosphate is still high. Why? Osteoblasts are not affected there. But here in multiple myeloma, this is very important. In the serum profile, two very important markers: calcium high, alkaline phosphatase normal. Very important. Okay, serum markers, multiple myeloma, right? Okay, did everyone understand that point? Right, all good. These are what is coming for your questions, huh? Now I will put some questions over the next few days. Try those, huh? Right. Then, guys, so we discussed two things under this malignant plasma cell. The third thing under this malignant plasma cell that I want to talk about, right, is some relatively rare causes. What are we saying, guys? If the malignant plasma cell mass becomes so large, right, that means monoclonal proliferation is very, very rapid and they become very, very large, right, in a short period of time, what happens? What is going to happen is, guys, one thing, it can affect the spinal cord, right? Because the vertebral column is going to get affected. It can cause cord compression, spinal cord compression, right? Another one is the cauda equina syndrome. Cauda equina syndrome, right? Both of these guys, very, very rare. Very, very rare. What is this cauda equina syndrome? What is cauda equina syndrome? What do you see? What is one of the main features there? I don't want you all to forget.
Passive paralysis of legs.
Right. Placid paralysis, correct.
Saddle area numbness.
Saddle area numbness, right? Do not forget that. You all know what the saddle area numbness no? You all sit on a horse, right? And you all know you have a saddle like this, right? So when you sit, right, I'm just going to draw the legs, like the one leg on this side, the other leg on that side. Wherever the saddle is touching your body, that is called the saddle area, right? There is going to be numbness in that area, saddle area numbness. Okay, this is cauda equina syndrome. Very, very rare. Okay, cord compression and cauda equina syndrome both. Apart from that, you can have loss of bladder control, loss of bowel control, all of that can be there. Erectile dysfunction, right? All of those can be there. These are very rare in multiple myeloma, but possible, right? Right. So those are about that. Point number 3, the malignant plasma cell. Then we come to the final point, point number 4, right, of the clinical correlate and the pathology. We'll talk a little bit about that hypercalcemia. The hypercalcemia. What can that do in our body, right? First thing, guys, hypercalcemia, right? Now this multiple myeloma, this is a cancer, right? This is a cancer. Generally, if you consider cancers, do you think they are acute, like daily processes, one day, or will they progress for a long period of time? What do you think?
Takes time.
Yeah, it takes time. It takes quite a bit of time, right? So this hypercalcemia, guys, specifically, they can go and deposit in the kidneys over long periods of times, causing what? Calcium deposits in the kidneys. Causing what?
Kidney stones.
Kidney stones or nephrolithiasis. Kidney stones, right? Okay. Then another thing, if you all remember what hypercalcemia does, we talked about this, right, in some of our chapters, right? In some of our chapters. What did we say, guys? There is going to be something called targeted autophagy. Targeted autophagy of aquaporine type 2. Targeted autophagy of aquaporine type 2. Do you all remember where we talked about? If aquaporine type 2 is going to be destroyed, what's going to happen? Tell me step by step. What happens next? What is the function of aquaporine 2? First, tell me.
Water
Water reabsorption in response to what? Why is aquaporine 2? In response to ADH. Under normal physiology, when ADH is high, aquaporine will be expressed. And then what happens? Water reabsorption. Right. Now, if the aquaporine 2 is being destroyed, even though ADH is coming, can we reabsorb the water?
No.
No. If there is a problem like that, what is your diagnosis? ADH is coming, ADH secretion is fine, ADH is coming to the kidney, but at the kidney, aquaporine is not working.
Diabetic insipidus, which is resistant to Receptor
Diabetes insipidus, which is
receptor resistant.
don't go so much. Don't go so much. What are the two types of diabetes insipidus?
Cranial and renal.
Cranial and nephrogenic. Cranial and renal. Yes. Which one of the two? Which one of the two?
Renal.
Renal, nephrogenic, right? Because the ADH is being secreted, no problem. It's coming from the brain, right? Hypothalamus, right? ADH is coming. So no issues there. So what is happening? The problem is the aquaporin doesn't come to its target and do the work. In the kidney, it doesn't do the work. What is that? Nephrogenic diabetes insipidus. Go through the work. I taught you all this chapter. Go through your work. Nephrogenic diabetes insipidus. What are the manifestations? What are the manifestations? Nothing. Don't remember anything. Tarinder?
Polyuria.
Polyuria. What else? What else?
Natriuria.
Yeah. No need to go. Polyuria, polydipsia. When they have excessive urination, what they feel thirsty. Polydipsia is going to be there, right? When they are urinating a lot, right? At one point they can't even compensate. That will cause serum hyposmolarity, right? We have talked about all of this, right? Dehydration, all of that can be there, right? Okay, no need to discuss that now. But just know this is another effect of this hypercalcemia. Why this targeted autophagy of aquaporin 2 happens due to calcium, guys? We don't know the mechanisms clearly. How calcium can go and directly cause problems with aquaporin 2, we don't know. But it does, right? Right. Then apart from that, when calcium is high, what is another thing that can happen? Related to your heart. Calcium too much. What happens? No idea? Excellent. Arrhythmias, right? Cardiac arrhythmias. Then again, guys, in the gastrointestinal tract, right? Hypercalcemia can cause constipation, right? By disturbing the gut mucosal cell epithelia, right? So these are the things that we can expect with hypercalcemia. Here, guys, just note down this nephrolithiasis, right? And this diabetes insipidus chronically over a long period of time, eventually it can lead to what? Chronic renal failure. Now, chronic renal failure, lab tests, tell me, what do we see? Doctors, answer.
Serum creatinine.
Excellent. Serum creatinine high. What else?
Blood urea nitrogen.
Excellent. Blood urea is going to be high. Okay, my pen stopped writing. Give me a second. Yeah, there we go. Blood urea is going to be high. Anything else? What about the GFR?
Low.
AGFR will be low, right? So these are some manifestations and some labs, right? Is this clear? Okay, right. Now, guys, we have left what? The diagnostic criteria and the management. That will take maybe another 20 to 25 minutes, right? Do you all want a break or do you want to finish the class? Drop me a message in the chat box, right? Let me see the chat box. What do you all want to do? Break, 10-minute break or continue? Okay. We have one. So we have one response. Okay, okay. Right, continue, finish. Okay, Tarinda says break. So Tarinda, I think you're alone again, as always in this department, right? Everyone's asking to finish it off, guys, right? Okay, so Tarinda, so let's power through. Right, let's finish it off. Look at this. We'll come now to the diagnostic criteria, right? Diagnostic criteria. Diagnostic criteria. The diagnostic criteria, guys, right? It has been modified since a long time. We initially 2001, 2007, now 2014 was the final modification. So we'll study the most up-to-date one, right? Here is the diagnostic criteria, guys. For us to diagnose a patient as having multiple myeloma, right? They have to have, first thing, their bone marrow plasma cell infiltration should be greater than 10%. Greater than 10%. Why? What did we say? If it is less than 10%, usually we won't have clinical manifestations. And what did we call that? If it's less than 10%. What is it? Answer. Hey, quickly. Less than 10%, no manifestations. No answer.
MGUS.
MGU is monoclonal gammopathy of unknown significance. MGUS, right? So that's the first criterion: bone marrow plasma cell infiltration greater than 10%. Second one, guys, right? We have something called an MDE, myeloma defining event. I will tell you all what these are. Don't worry, right? And the third one, we put a plus or minus because this third one is not essential. It's a plus or minus. What we call crab criteria. It's not essential. It's not essential. Right? So this is the diagnostic criteria. Now let's take a look at this. Right? Bone marrow plasma cell infiltration greater than 10%. You all already understand. Right? This is the first one. The second one is this myeloma defining event, MDE, myeloma defining event, right? What are these myeloma defining events? There are three, guys. The first one, the bone marrow plasma cell infiltration is greater than 60%. That is a myeloma defining event. If it is more than 60%, doesn't matter. It's myeloma. Right? Another one. The serum free light chains. Now, what do we know? Light chains can be released into the blood as well when there is multiple myeloma. We said most common one is IgG kappa. So the kappa will be very high, right? So what we do is, guys, we take the patient's serum, we look at the light chains, right? Now, some of the light chains will have come from a myeloma protein, from a myeloma cell. Other light chains will be from their normal plasma cells, right? So what we do, we check the serum free light chains, and what we specifically look is the involved light chains involved in producing multiple myeloma divided by the ones uninvolved. That means the normal light chains, right? So basically, we are talking about unfolded light chains versus the normal, nice looking, beautiful light chains, right? We look at this ratio. This ratio, guys, if it is greater than or equal to 100, that is another myeloma defining event, right? Okay, myeloma defining event, right? Then the third one is, guys, we tell the patient, do an MRI and come, right? We'll take a look at your bones, right? So if you see an abnormal MRI, what do we mean by this abnormal MRI? Look at this, greater than or equals to 2 focal lesions. Basically, our lytic lesions, right? Should be more than or equals to 2 or more. The other one, right? Each of those should be greater than or equals to 5 millimeters in size, in diameter, right? That they should have at least 2 focal lesions, and those 2 focal lesions should at least be 5 millimeters in size, in diameter, right? So these three are our myeloma defining event. Now, what's important here, the patient can have any one of these three. If any one of these three are there, that is myeloma, right? That is a myeloma, right? MDE, right? Then guys, the plus or minus the crab criteria, plus or minus Y, right? They are not essential for the diagnosis. They can be there or not, can be there or not. What should be there, guys? The ones that must be there are this one, plasma cell infiltration greater than 10%, and at least one of the myeloma defining events must be there, at least one. Crab can be there or not, right? No issues, no issues. What are these crab, guys? What are these crab? Just, it's a mnemonic, they have made it. So one is hypercalcemia, the C, calcemia, hypercalcemia. The R is for renal failure, right? The A, anemia, right? And the last one, B, for bone lytic lesions, right? CRAB. This hypercalcemia, guys, usually, what is the range? We say calcium, serum calcium, if it is greater than 11.5 milligrams per deciliter of blood, right? Okay. Renal failure. How do we look at renal failure? How do we identify renal failure? Any idea? Anyone? Guys? Renal failure. Answer. I'm going to ask now. Okay. Shashank, renal failure. How do we see renal failure?
Urinalysis will see like protein.
Okay, urinalysis. Okay. What about the blood? Blood.
Creatinine.
Serum creatinine. That's the easiest one. That is the most important one in our renal profile, right? Serum creatinine, guys. Usually, if it's greater than 2 milligrams per deciliter, right? That indicates renal failure. Anemia. How do we diagnose anemia? No idea? Anemia? No? Hemoglobin less than 10 grams per deciliter. This is anemia. Or guys, there are some new criteria where they say now some states, some areas where we all are going to practice medicine, make sure you all are familiar with the guidelines. In some areas, guys, this hemoglobin less than 10 gram per deciliter is not accepted. What they say is, just put it as an O. They say 2 grams per deciliter less than the patient's normal level of hemoglobin, because some patients, due to some other abnormalities or other issues, they can have less hemoglobin, right? Due to some other chronic diseases, right? So in those kind of patients, right, we cannot say because they have less hemoglobin, they are having multiple myeloma. No. Usually, if you notice that the hemoglobin has reduced over the past months or past few years, about 2 grams per deciliter than their normal. Let's say normal they had about 9 or 8. Now it's about 7 or 6. That is suspicious. Maybe if the other manifestations are present, yes, it's likely that it's multiple myeloma. So just look at the guidelines of where you're going to do your exams or where you're going to study. Usually we say anemia when it's less than 10 grams per deciliter. And then bone lytic lesions, guys, usually we can see it in the X-ray, X-ray, right? And what is another serum test? Alkaline phosphatase, just note, it's normal. Alkaline phosphatase is normal, right? Okay. Did everyone understand this? Right? Here, guys, put another note under this diagnostic criteria, right? There are some prognostic markers. That's prognostic markers. Now, why these are happening like this and how we do not know, and absolutely unnecessary for MBBS level, right? But the prognostic marker we should know for our MCQs. The mechanism is unclear, but the marker should be known. Huh? Look at this, guys. One of them is beta 2 microglobulin. Beta 2 microglobulin. Guys, turn your cameras on. Right? I can see only two faces. Difficult to teach, guys. Need to see how you all are taking in the information, you know. Right? Turn your cameras on. Cameras on. Right. Right. Good. Look at this. Only one camera turned on. Huh? Okay. Right. Look at this, guys. All right. It's okay. It's okay. Right. Nihal, it's okay. Right. Look at this. Beta 2 microglobulin, guys. What is this? Right? This one, they say if it is elevated, you in a multiple myeloma patient, you check their serum proteins. If their beta 2 microglobulin is high, if it is high specifically, guys, they say if it is greater than 4 milligrams per liter, right? If it is high, right, it is, they say, bad or poor prognosis. Poor prognosis. Now, why this is, how this is, we don't know, right? It has been associated with the disease, right? We have seen that people who have this are having very severe disease, but we don't know why exactly. Another one like that, guys, right, is the CRP, C-reactive protein, right? C-reactive protein also, if it is high, now ESR can be high, we know that. When there's hyperviscosity, ESR can be high. But they say if the CRP is also elevated in a multiple myeloma patient, that's another poor prognostic indicator, poor prognosis, right? And the third one is, guys, LDH. LDH, lactate dehydrogenase. We talked about this in hemolytic anemia. We said when there is hemolysis, LDH can be high. But here, guys, that is not the mechanism. For here, it's not the hemolysis. Huh? They say when LDH is high, again, that is a bad prognostic indicator. Right here, it's something to do with tissue damage and high tumor load, guys. High tumor load, right? We don't need to discuss the mechanisms, right? Very in depth, not necessary for MBBS, but these prognostic markers are necessary. These come for your MCQs, right? These are all three are poor prognostic markers, right? They indicate that the tumor load is very high. Tumor load is very high. Okay. Then in blue color, you can put another indicator, right? Cyclin D1. Now tell me this, right? Cyclin D1, according to what you learned, if you take the patient's serum and if you see a lot of cyclin D1, what do you think that indicates? Huh? Based on what you learned, based on what we learned, guys, if cyclin D1 is very high, what does that probably tell you about the disease?
Uncontrolled cell proliferation.
Yes, uncontrolled cell proliferation. So basically, we would assume, right? Good, Dirshani, good. Basically, what we would assume is that this is also a bad prognostic marker, correct? We will think that the disease is severe. That's why this is happening. But paradoxically, right? This is the issue, guys. The explanations are not there for these. We don't know why. Paradoxically, if we see cyclin D1 high in the patient's blood, we take it as a good prognostic marker. Good prognostic marker, right? Okay, for some reason, right? So we can imagine maybe that the plasma cells are being destroyed and they're releasing the cyclin D1 into the blood. Maybe we can imagine it like that's not the mechanism. Huh? That's not the mechanism. That is just my hypothesis to make it easier for us to remember. Because we have to know that cyclin D1 is the only good prognostic indicator of multiple myeloma. Beta 2 microglobulin, CRP, LDH, all three bad. Bad, poor prognosis, poor prognosis. Cyclin D1 is the only good prognostic indicator. It's a paradox, right? Based on the pathophysiology and the mechanism, it seems like it's the opposite thing, but that's what it is. That's what it is, right? Okay, all right. So these are for your MCQs, huh? These are for your MCQs, right? Right. Then finally we come to the management, guys. Treatment part. MX, multiple myeloma. How to treat? How to treat? First thing, guys, when a patient comes with a severe pain or some emergency condition, right? Or if they have gone into renal failure, so we have some supportive therapy. Supportive, first to stabilize the patient, right? To stabilize the patient, or some emergency medications. What are these? What are these? One of the first things is, guys, specifically, I think I have put these in here. That's good. Yes, no? There is this. Yeah, fluids. First thing is fluid resuscitation. Why? For your dehydration, specifically if they have the diabetes insipidus or if they're going into renal failure, right? To prevent the dehydration, we can give some fluids, right? We can give some fluids. Bisphosphonates. What are these? How do they work? What do they do? Why are we giving this? Answer.
Osteoclast activity.
Excellent. These ones will inhibit osteoclast activity. So what are we actually trying to do here? Why are we trying to inhibit osteoclast? What are we trying to treat?
Hypercalcemia.
We are trying to correct the hypercalcemia. Okay. Analgesics, guys, specifically for the bone pain, because some of these patients come with severe backaches, right? See, unbearable backaches, right? Severe backaches, right? So you can give some analgesics, right? Plasmapheresis, guys, this is not commonly done. This is done if the case is severe. What do we mean by if the case is severe? If we are seeing manifestations of thrombocytopenia. We said thrombocytopenia, neutropenia, these are usually seen if the disease is severe. So if we are seeing manifestations of thrombocytopenia, gum bleeding, epistaxis, right, petechiae, right, ecchymosis, these kinds of things, then there is a place for plasmapheresis, right, transfer of the plasma. Then, guys, if there is some severe anemia, we can give them blood transfusions or EPO injections, right? Erythropoietin injections can be given, right? Again, not very commonly done, guys, unless the anemia is very severe, right? And then infection prophylaxis. Why? We know in general, multiple myeloma, although it is a monoclonal gammopathy, right? Those immunoglobulins, although it's high in number, they are dysfunctional. So what is happening? Our normal immunoglobulin levels start dropping, so we are more prone to get infection. Here, guys, we can put them on broad spectrum antibiotics, right? Some antifungal agents, specifically if they are, guys, these antifungals, if they are having at the same time concurrently, if they're diabetic patients, right? Antifungals can help a lot, right? Okay. And then in some more developed countries, they also have immunoglobulin injections, guys, right? We don't usually use them, but there is a place for those also, right? We take immunoglobulins from a healthy person and inject it, right? Okay, right. Now, so those are the main emergency things, right? Just to stabilize the patient. Then how can we treat multiple myeloma? Now look at this, guys. The first thing I want you all to know, multiple myeloma is not necessarily a fatal illness, right? It is not necessarily a fatal illness. Nowadays, right, we have more than enough treatments for multiple myeloma to control. But having said that, what do you think? Do you think multiple myeloma is completely curable? Is it curable? This cancer of plasma cells, is it curable? What do you think?
No.
Right? No. Excellent. It is not completely curable, guys. But what we can do is bring the disease into what we call remission. Remission. That means what? Well controlled, right? Manifestations are minimal, right? No issues. The patient can almost have a normal life, almost a normal life, right? This is what we call remission. This is our goal. When we are treating multiple myeloma, the goal is to bring the patient into remission, right? So the other important thing is those days, the moment you hear cancer, now what is multiple myeloma? Plasma cell cancer, plasma cell neoplasm. Those days, the moment you hear cancer, what does your mind go to? When you hear someone has a cancer and they are getting chemotherapy, what does your mind go to? Huh? The severe side effects, no? Hair loss, right? Loss of appetite, they become very thin, vomiting, nausea, right? Those days, that's what we thought, right? Immediately when you hear chemotherapy. Now for this multiple myeloma, there are still those medications. Those medications are still there for other diseases. But for multiple myeloma, guys, just note down, nowadays, we use what we call, we do not use cytotoxic chemotherapies, cytotoxic chemos, right? We don't usually use them. We don't need them for multiple myeloma, cytotoxic chemotherapies, right? We have other options now, novel agents, right? New products, biologics, right? That can help bring the disease into remission with minimal side effects. And one of the most important examples is this, bortezomib, right? Bortezomib, right? One of the most commonly used ones now, and it's a novel agent, right? Minimal side effects, right? This one, guys, bortezomib is a very complex drug, where if you look at the mechanism of action, you will have to take a specific pharmacology course, right? Very complex mechanism of action. In summary, in very, very short, what it does, right? It arrests the cell cycle, at G2. It prevents the cell going from G2 to M, right? Arrest the cell cycle. That is in absolute short. Okay, it does a lot more things, right? Bortezomib, right? In absolute short, it arrests the cell cycle at the G2, doesn't allow it to progress into the M phase, right? So what will happen, guys? The clonal expansion, monoclonal expansion rather, right, will be reduced or stopped, right, in the myeloma cells, right? So it is excellent to achieve remission, minimal side effects, right? No hair loss and these things. They can have a little bit of nausea, but still not too severe, okay? Then, guys, another thing, right? Here, leave this number 3 and 4 and 5. We'll leave a little bit, discuss this a little. We have another option here. If, put this down, if the patient is less than 70 years old, if the patient is less than 70 years old, right? Now, what did we say? Multiple myeloma, primarily a disease 60 to 70 years old. Very unlikely that it is below those ages, right? But if the patient is less than 70 years old, we can think of stem cell transplantation, right? This stem cell transplantation, guys, it should be autologous. It's an autologous stem cell transplantation, right? Here, there is another drug here, guys. Stem cell transplantation plus something we called, write this down, melphalan, right? What is this melphalan, guys? This is a DNA and RNA synthesis inhibitor. It is more of a targeted therapy, guys. So it goes to the plasma cell and stops the DNA and RNA synthesis, right? So you can give some melphalan, right? Try to bring the patient into a little bit of a remission, and then you can think of a stem cell transplantation if they are under the age of 70. Usually, guys, if the patient is greater than 70, we do not usually do stem cell transplantations, right? We usually don't, right? Unless maybe it's an exceptional case. I don't know, maybe like a very high position person in the country, maybe a prime minister, maybe a president or someone like that, and they absolutely require the stem cell transplantation, then they might consider. But if not, we usually don't, right? If the patient is
Sorry,
greater,
Prashan,
yes,
why is it contraindicated?
it's not
If
contraindicated. It's just that so when we weigh the advantages and the disadvantages, guys, now a patient greater than 70 years old, the average life expectancy of a human, let's say, it obviously depends from region to region. In our regions, in Sri Lanka, is just under 70, just under 70. And then South Asian countries, it's between these areas, 70 to 80 sort of, right? So when you consider the life expectancy, the complicated treatment procedure of stem cell transplantation, and the expense, when you consider all of that together, guys, it doesn't pose an advantage. Even if you successfully do the stem cell transplantation, the patient might die in 2 years because he's reached the end of his life, right? Not because of the multiple myeloma, right? So considering all of that, it's not contraindicated. Huh? There's no contraindication. It's just that we don't take that chance, right? It's unnecessary, right? So if the patient is greater than 70, we have some better options, right? If they're above 70 and they are very healthy, they're very fit, right? We have a drug called thalidomide, guys. Thalidomide, huh? Thalidomide. Now, thalidomide, right? Another very potent drug. What is this? I mentioned this when we were discussing. I didn't mention the word thalidomide. This is an interleukin 6 inhibitor. Now, does everyone understand how this thalidomide works? We have talked about in the physiology, the role of the interleukin 6, right? Okay. So this is an interleukin 6 inhibitor, right? So it induces apoptosis, right? Then another one that we have is, guys, if the patient is above 70 years of age and they are very fragile, they are very weak, guys. Let's say they're having other comorbidities, diabetes, hypertension, cholesterol, things like that, right? If that is the case, we can again go with our melphalan, right? Melphalan. Okay. These are some options that we have. Then again, here the same thing, guys. We have mentioned this stem cell transplantation, right? We've discussed about that now. Interferon alpha also has a place, guys, right? It has some anti-proliferative effects, right? So it can help prevent the monoclonal expansion or reduce it to some extent, right? And then radiotherapy. Now, radiotherapy, tell me this. This is a plasma cell neoplasm, plasma cell cancer. Plasma cells are produced in your bone marrow and they circulate in your body. So are you going to do radiotherapy for the entire body? To cover the bones and the blood and everything? Radiotherapy all over the body?
No.
What do you think? Yes or no?
No.
No. Obviously, no. You don't want to do radiotherapy all over the body. No, guys. Radiotherapy also has side effects, right? Where do we do the radiotherapy, guys? Write this down. These are your clinical questions. Your viva, these won't come in your papers. Where do you do the radiotherapy specifically for areas of bone that are damaged, that you have identified by X-ray, right? That have myeloma-induced damage, and there is seemingly no response to the chemo, no response to chemotherapy, and damaged bones. To those damaged bone areas, you can do some radiotherapy. Or near breakable bones with severe pain. Severe pain, if the patient is complaining of severe back pain, you do the X-ray, you localize the specific lumbar vertebral level where the damage is, and then you give radiotherapy there, right? That's how you give radiotherapy, not all over the body. Okay, for areas of bone damaged by the myeloma protein and myeloma cells, and they are unresponsive to chemo and they have severe pain. For those areas, you can do radiotherapy. Okay, right? Now, just before we end the class, guys, just take a look at these x-rays. No one will ask you, but just for you all to know, these are the lytic lesions, guys. These are the lytic lesions in the sky. I don't know if y'all can see through the Zoom screen share clearly, right? These are our, see, these are not meant to be there. These are lytic lesions, right? Lytic lesions, specifically in these bones, flat bones and some long bones as well. Here you can see, guys, see, these are large lytic lesion, right? A large lytic lesion there, right? Okay, and here may be some, see, very subtle, guys. These lytic lesions are very difficult. So I've been working in the rheumatology department for a while now. Difficult to identify these, difficult to identify lytic lesions, right? Most of the time they are not this prominent. So these images are from Google, guys. From Google, I have got these very prominently showing lytic lesions, right? Like these. Okay, but most of the time, this one, of course, very prominent. Look at this area, entire area has lytic lesions, right? Most of the time you won't see it like this, right? When they present to you, the x-ray, it's very difficult to see this. So you usually need some help from some seniors or some consultants, right? You will need some help, right? Anyway, for your undergraduate level, definitely not needed. Okay, you will, once you specialize in something, that's when you will need. And here the spinal cord, guys, here also we can see some lytic lesions, right? These areas have undergone some lysis. And here, can you all see this abnormal shape in the vertebra, guys? Right? What is this called? This vertebra has broken, right? This vertebra has broken. The normal vertebra looks like a nice square, right? What is this type of fracture called? I think I talked about this in another class. Excellent. This is what we call a vertebral wedge fracture. Wedge fracture, right? Vertebral wedge fracture, right? This results in kyphosis, guys, right? The patient's back, it bends like this, right? The patient's back bends when there is a wedge fracture like that. Okay. This is not a very severe one, of course, right? I have seen way more severe vertebral wedge fractures, and the patient, they're coming like this. They come to you like that, right? Okay. So these are some manifestations, right? Basically, I want you all to focus on the lytic lesions, right? If they are prominent, you can identify them, but most of the time it's a little bit difficult. Here, guys, Roule formation, Rolio formation, okay, Rolex formation, anything you want to call. And here, this is, guys, this is the bone marrow. When you look at it, this is normal. These are our normal plasma cells. What are the features of a normal plasma cell? The nucleus, of course, not very clear here, guys, right? But what can you see? You can see an eccentric nucleus towards one corner. Just next to the nuclei, guys, can you see like a colorless area? See these areas? See, they have not taken up the stain, right? See, these are our Golgi bodies, right? These are the Golgi bodies, right? So this is the normal picture. When you look at multiple myeloma plasma cells, guys, one thing, they are abnormal in shape. You can see these abnormal shapes, right? And they're basophilic. They are highly basophilic, guys. They have a very deep blue stain, deep blue. Normally basophilic, it's also blue purple, but these ones is highly basophilic, right? And can you see the perinuclear half or the Golgi body in these ones clearly? Not really. You cannot see the Golgi body or the perinuclear half here, right? Okay, and some hyperchromatic, the nuclei also looks a little bit darker. We call this hyperchromatic nuclei, right? Hyperchromatic nuclei. So these are the basic things, and this is the electrophoresis, guys. The electrophoresis, this is what we call the M spike, right? M spike. And then, yes, that's basically it for this chapter. IgG, right? Specifically IgG kappa subtype is the most common, right? Relative frequency 55% of all cases. Okay. That's it for multiple myeloma. Is everyone clear with what we talked about? Let me see some faces. Guys, turn your cameras on. I'm disappointed. Y'all are not showing me your faces. There we go. End of the class, turning the cameras. Right. Okay. Right. Excellent. Shashank's thumb has been up for a while now. Okay, good. So you have understood, right? Okay, guys. So that's about it, right? Okay, excellent, excellent. Thank you. Okay, you all have understood. I'm happy, right? So that's about it for multiple myeloma. I will be putting some questions, right? I will be seeing you all again, I think, on the 17th for the next chapter, right? So until then, try the questions. If you all have any questions, just if you all must have noticed today's class, guys, right? The pathophysiologies are not very clear, right? Now, what I want you all to do after the class or in the coming days, I know after the class, you all are just going to eat and sleep now, right? At least the most of you, right? First thing I want you all to do, since we discussed all the pathology and the pathophysiology and the clinicals together, I want you all to take a separate page, just write the clinical features that you can see in multiple myeloma in one list, just as a summary for yourself. Okay, because we made quite a mess there, right? So just make a summary of the clinical features and the treatments in one page. And the other thing I want you all to do, try reading the textbooks, try reading Kumar and Clark's, try reading Davidson's, right? Don't worry, yeah, doesn't matter even if you are in first year, right? Okay, no issues. You all can read the book. We've discussed everything, right? And more than what's in the textbooks. So just read through. And if you all have any confusions, drop me a message, right? Most of the mechanisms, guys, for multiple myeloma, right? Unclear, still unclear. Okay. So I hope you all understood everything, right? See you guys in the next lecture. Okay, that's it for today. All right.
Thank you so much.
Okay, you're welcome. See you guys.
Thank you. Bye bye.
Thank you.
Right, bye-bye.